Okay, thanks so much to our speakers for those great presentations. I heard a few common threads and some distinctions. I'll note before we begin our discussion, I heard a lot about the complexities and distinctions of the control strategies and the interventions that are at hand for all three different diseases, the importance of global goals and campaigns and how they drive many of the efforts, how the models depend so much on effective implementation and human behavior, the costs and importance of identifying and finding cases in all of these diseases, and the testing strategies, how the technologies, medicines, and vaccines affect our calculations, and finally, a concern about future investments and how important that will be for the work that's gone on so far. So now we have a half hour for discussion, questions, answers, comments, reactions. What I would say, I see a couple of initial questions, which is great, and what I'd say is maybe if you could put your cards up, it will increase the odds that I can see them and make sure I get everybody in. So I saw Jeff first, and then Jennifer, and then I can't see your card. Ramadan, great. And then we'll keep going around the room. Jeff.
Thank you, Tom, and thank you. I thank all of you for your great presentations in 10 minutes and for the work that you do on these diseases, which represent a huge cause of morbidity and mortality globally. And my question relates to that fact. Given that you've all modeled these diseases, which use the expression no-brainers. They're such great causes of loss of health globally. How effective or how impactful do you feel that the results of your modeling have been in influencing policymakers and decision makers? And what advice would you have for people who are going to be using modeling in the context of diseases that aren't even occurring, such as potential future pandemics and emerging diseases? And helping those modelers produce products that will be impactful and influential in forming policy decisions.
Anyone?
I'll go. First of all, thank you. That's a great question. It's actually a question a lot of people ask, and I think I've been really fortunate to be able to work with the GPEI partners and collaborate pretty closely with them over the course of the work that we've done. And to me, that's actually been critical. So I do think that our work actually has had a significant impact on the program. We find that really the key is that we have open lines of communication with all the partners. So we talk to everybody. We try to understand where they're coming from, what they're thinking. We try to help all of them understand when there are differences emerging. So we sometimes see where one partner might be going in one direction, another one's going in another direction, and we try to help intervene early to get the discussions to happen. I do think that in the case of polio, the partners have been very good in terms of their interactions with us in highlighting where they think things are going and looking ahead and allowing us then to try to have the modeling available at the time the decisions are made, which has been really important because often we're, as modelers trying to catch up. And I think one of the more important things for us has been that we've had sustained contributions. So this is a large, complicated model. I tried to emphasize the biological and epidemiological complexity because this is a very, very complicated world that we live in. And if we don't have models that capture that and can speak to both the ministers of health and the minister of finance of different countries, it's not going to work very well. So in our case, the key thing has really been talking and listening to all the stakeholders, engaging with them to find out what their questions are, and then really trying to answer their questions and helping them understand not only what they think they want to know, but also what are other things that are important to them that they may not realize. So thanks, it's a great question, and I think the key thing is communication.
Other comments?
Yeah, I think as well a very important question. I think, like Kimberly said, dialogue with the policymakers is very important. But I think it's also on us to devise, on us researchers to devise methods that are that help us to get answers out more quickly. I mean, there is this idea that everything needs to be put to a randomized controlled trial where we then wait 6 years until we have the result. Modeling of course, is another approach. But then there's a third approach, which I see coming in more and more, because, I mean, when we talk economics, it's not only theoretical economics, but also the tool set that we economists have, the quasi-experimental methods, such as difference in difference analysis, or regression discontinuity design. And I see that more and more there's an openness in the public health community to use these kind of approaches. And of course, they are cheaper, they are faster, and they rely on observational data that may already be there. So I think it's an openness among all to adopt many different approaches. Thanks.
Anna?
I think two things. I think the underlying environment is really important. You can do the same analysis in one country and do the same analysis in another country, and one country will listen and one can't. Even in the countries perhaps where you think your analysis is not helping or changing decisions, it often removes a blockage to a decision. So I give the example of Ukraine, and we talked about incentives. There are lots of incentives to not treat TB patients in the correct way in the Ukraine. But the government for many years sort of argued that it wasn't economically viable, and then by showing it was, we removed one of the arguments and moved the conversation onto the real conversation. In other environments, the economic, and that you know, that's dependent on the country and depending on the time in the country. The thing that I think is really important is the institutionalization of this advice and capacity building in this advice. You know, many times researchers and people fly into countries with this very complex models in 2 weeks and say, here's your answer. The work we've done in South Africa has been doing for years and years, and patience, and it's taken a long time. And sometimes we push things, and sometimes we've modeled things we haven't wanted to model because that has been the request. So I think that long-term engagement helps you notice when those windows are there to make a difference, but also builds local ownership. So I'd highlight those two things.
Great. Jennifer?
Thank you all. That was fantastic. My question is around TB and HIV. These are two conditions where treatment confers a certain burden on the individual. And Dr. Hauk mentioned altruism. This kind of raises the ethical principle of reciprocity. And so if an individual is taking on a burden, whether that's a burden to their health, to their economic livelihood, we as public health then owe them a certain debt. So to what extent are individual level economic incentives, social supports being used as part of HIV and TB prevention and treatment programs, and is there evidence for their efficacy?
Jennifer, I meant to say earlier, would you mind just saying what institution you...
Oh, of course, yes. I'm BC Centre for Disease Control in the University of British Columbia.
Thanks so much.
Yeah, I mean, they are being used. They're not being used to change people's behavior. They've been used because different organizations recognize the burden on TB, or at least that has been for a long time. However, having said that, recently, 2 years ago, there was a study by someone called Tom Wingfield, and I can give you the reference, that started to look at the impact of these social support and conditional cash transfers, and I'm sure Catherine can speak more about these, on TB treatment success. And indeed, there was an impact on its success. So clearly, it was an incentive as well as just a sort of a humanitarian thing to do. I think generally the TB world has recognized this and is trying to bring attention to this issue through their measurement of catastrophic costs. It is difficult for health people to sort of work with social sectors, and that's also important for our economic analyses, because then we're looking at different types of benefits as well and different types of investors. So it is happening, but it's happening slowly, and it's difficult to get moving on the ground. And happy to share those references with you.
Yes, thanks for the question. So I think that's an important issue, and over the past, I think, 5-10 years, we have seen a few studies looking at the efficacy of and cost effectiveness of conditional cash transfers. I mean, they are mainly in the area of adolescent girls to keep them in school, because there is a link between early infection with HIV and school attendance. The evidence is inconclusive whether they are efficacious. I think it depends on the subgroups. So you need to go into the details of who is receiving the transfers and how are they receiving them in order to make an assessment whether they're effective and whether they are cost effective. But I think that's definitely an ongoing area of research that's interesting.
Ramanan.
Morning. All excellent presentations, and thanks for the work that you do.
Raman, would you just tell us again where you're...
So my name is Ramanan Lakshminarayan. I'm at CDEP in Princeton. Peter Sands made the point that much of the economic consequences for epidemics or new emerging outbreaks is really in the form of sort of fear factor in a sense. And that is obviously missing to a large extent with these diseases as people get used to them. And at the same time, although there's cases and we tie these direct costs to cases, finance ministers have, I think now are in a sort of, they face this idea of, billionitis. Everything which is with infectious diseases costs billions, some order of billions. And we've all been complicit in adding zeros to those billions. And it's hard to really provide any sort of meaningful analysis here that would help them make that differentiation, because then they see everything is in that order of magnitude. I wonder if in tying things just to cases, as we generally tend to do, we do two things. One is, as the disease starts going down, we give the perception that it's going away as a problem, and this has happened in the past. When Sri Lanka got rid of malaria, they thought, this has no economic impact, no real impact, and then it came back a few years later. And this happens routinely when, people stop paying attention. Venezuela now has polio again, I believe. So this is an issue. And I wonder if in not now transitioning the conversation to the impact of endemic diseases on things like agricultural output, on industrial output, on people who are not affected by the disease, we are missing an opportunity. And in fact, just this morning there was the news that Paraguay is the first country in the Americas in 45 years to eliminate malaria. And that reminded me of something. Gladys Conley, who was an economist who worked down the road at PAHO, she spent an entire career in Paraguay doing this very interesting work showing that the major impact of malaria in Paraguay was really not on people who got malaria. It was on the crop choices that the people who did not get malaria made, because in anticipation of malaria during the harvest season, they chose not to plant cotton and they planted potatoes because that was less susceptible to disruptions when everyone got malaria potentially during the harvesting period. So in a sense, the impact was really on choices that people have made. And in that sense, it's much more similar to the outbreak situation. It's really the fear factor in a sense, and how it changes behavior profoundly for the 99% of people who never experience an infectious disease. So what do you think in the context of your disease is that we can really make that transition? Is that a useful way of thinking about this?
Great question, as always, Ramanan. So first of all, let me say, I think that the critical issue here is that, in fact, what we have really discovered and demonstrated is that what we need to have people see is the benefits of cases prevented, not tell them how many cases are happening and have them look at how much are we spending compared to how many costs there are, but how much are we spending compared to how many cases are we preventing, and really focus much more on that as the metric that they then start to appreciate. Now, this is a challenge because you can easily count dollars that you're spending, but you can't easily count cases that you don't see. Right. So this is where the modeling actually plays a critical role. And in fact, in the context of what was happening in the global health space in the mid-2000s around polio, there was a lot of this, how much are we spending and how many cases do we have right now, as opposed to how much are we spending and how much are we preventing. So I think one of the key things that we all do is help people see by modeling what it is that they're preventing and actually try to put economic value on that. And I just think we have to figure out how to make sure that the folks who are on the receiving end of this realize that even though the epidemiology might be saying that there's not much there, the potential, at least for these infectious diseases that can easily come back if you take your foot off the gas, is a reality. And I think that's really, where we have a big opportunity to try and reframe. And certainly it's something that we've tried to do in the polio area, and that it has been reasonably successful to date so far, in my opinion. With respect to Venezuela, I have to say one of the things that we really have to recognize with all microbial threats, particularly the ones that are transmissible and readily transmissible, is that when we do implement strategies and then we take those strategies away, things come back, and even though people don't expect them to come back, they do. And in the case of polio in Venezuela, we're certainly seeing the possibility of not just circulating vaccine-derived polioviruses or CVDPVs coming in to this region of Venezuela that's affected, but everything else, measles, rubella, you name it. I mean, and PAHO has historically had a very strong immunization program. So the idea that there is any kind of a wavering commitment to this is a signal that we should all be looking at. And again, I think on the behavioral side, we need to look at not just fear, but so what is behavior in terms of commitments that people have made, and how are these all trickling through the entire system? So thank you.
Yeah, thanks for the question. I think it's very difficult to answer this. I need to think a bit more about it. I think in the context of HIV, obviously, is the arrival of efficacious treatment, where we clearly see in the empirical evidence that individuals take into account that the costs of getting HIV infection have become lower. And where HIV is now developing into a disease that is not a life-threatening thing like it was for us in our youth, but something where you pop a pill every day. And of course, this will change the incentive structure of individuals. What to do about it? Well, education and making clear that the side effects of this treatment are still there and very real, and we do not know how when we observe individuals as they go towards the end of their life, how this affects their health. And in the context of a low-income country, I think it's recognizing that there are competing mortality risks. And if there are so many competing mortality risks, then a taxi driver that you ask, are you worried of getting HIV positive? The taxi driver will say, I'm much more worried of getting malaria because this will kill me within 14 days. HIV will kill me maybe in 7 years. I will get sick, then I start taking the tablets. I remember when I visited facilities where we did our trial, where antiretrovirals were given out for free, but when we walked across the market, there you could see a sign, you need to pay $1 to use the toilet. So I thought, what is really are the priorities right? I don't know. So I think just to recognize that the time preferences and risk preferences of individuals are different and target policies according to that.
Thanks. I suppose I have 2 points really related to other people being impacted and how they may be impacted. I think health workers is one group who there's been a lot of concern about TB, and there's been a motivation to adopt new technologies and have new practices to protect health workers and the way they're behaving towards people. So that's one of the kind of external effects. But the other one, I think, which is more directly related to your question is, and it is work we're just starting, is understanding when people go into economic catastrophe who they're borrowing from. And I suppose the question is, if, yes, that family is very poor and maybe they themselves are not losing that much productivity, but they're borrowing from their richer relatives, they're borrowing from people who are productive, how are they saving, how is that stopping their investment? And I think all the studies at the moment are just looking, as you said, at that individual, at best within household sort of economic coping mechanisms, but haven't gone into the community. And as we know, these households are, in many countries, aren't contained households and nuclear families. So I think that is a really interesting area to look at further.
Patrick Hickey.
Good morning. So I'm Patrick Hickey from the Uniformed Services University. I'm the chair of pediatrics there. And 2 weeks ago in my prior job, I led the Army's PEPFAR portfolio at the Walter Reed Army Institute of Research. So my question's related to really for polio, for HIV, and similar diseases where, at least in certain geographies, we're trying to approach control of the epidemic. And one of the things that PEPFAR struggles with right now is understanding the efficiency of resource allocation as you approach control. And people in the field will tell you, well, you're intrinsically more inefficient, and stop harping on the fact that we're spending so much money to find fewer cases. But the person who controls the purse strings wants everything done for less money. And my question is, how robust or how mature are those models? Because I think what we've heard a lot of you were discussing was sort of front end, sort of burden of disease and the cost of a disease. But what we don't know is what does it really take to get that last mile, and how much resource intense is that going to be? Thank you.
Great question. So this issue of getting to the last mile is a complicated one, and I think one thing I want to emphasize before trying to tackle the economic side of it is one of the critical things that I think the polio eradication program has done is really had accountability for performance in countries, and although it's been highly imperfect, the way the program is structured, it really does try to drive accountability performance. There's a lot of oversight by the partners, and it drills down. And I think that's really a critical thing, because as you get closer and closer to that last mile, you have to figure out where that last mile is, and sort of what's really happening in that situation, and why are there these un and under vaccinated or un and under treated individuals, et cetera. So part of it is really that there's a learning process that you go through that then leads you to different strategies in different places, because one size really doesn't fit all. In terms of characterizing that for economic models, I can say that on the polio side, we certainly have tried to account for the fact that there are things that are uncertain and things that don't cost more than we expect them to. So we've tried to do a little bit of that. I think one of the challenges we've had is that sometimes the strategies have been optimistic or not implemented in the way we thought they would have been. So again, there are things in our modeling that we assumed that might not have been exactly what happened in the field. And so part of it is really understanding those two things. With respect to prospectively characterizing the economic costs associated with increasing coverage as you try to reach the next, most difficult part, there is a paper that Sachi Ozawa and I and Tatenda worked on that actually just came out in Vaccine, that tries to use what is the available evidence out there to characterize a cost function to try and get at that. So we are trying to do that in the context of modeling what measles and rubella eradication would cost, because we do know that in fact there is an increasing cost function, or at least it looks like an increasing cost function. So there are economic tools out there to try to do that. And I think the critical thing is for everybody to realize that again, it's if you're going for an eradication goal, you are going for something where you're going to have to pay those higher costs to get out there, but then long-term benefits should be significant to outweigh that.
Yeah, I think your question plays on two aspects. The first one, I think, is an equity efficiency trade-off question. Yes, the costs for reaching the marginal last case can be incredibly high, but if society decides that we want to target, or we want to benefits to reach these hard to reach key populations such as sex workers, injecting drug users, then we should weigh efficiency considerations against equity considerations. And I think it's on us economists to make clear to quantify the sacrifice that is made here in terms of efficiency. For example, we found that just finding on testing one injecting drug user in Thailand might cost several $1,000s. Now, is that worth it? It's on society to decide. With respect to elimination, yes, eliminating the last case, or finding the last, or preventing the last case of a disease is very high. The marginal costs of that are very high, not justified by the immediate benefit to this one individual. However, you have to count against that the elimination or eradication dividend for not only a country, but for all the neighboring countries, possibly the world around it, which could be enormous. And in the case of smallpox, calculations have shown that the elimination dividend was very high, because all further vaccination could be abandoned, surveillance could be abandoned, and that was a huge success for the world, I guess. Now the question is, will this apply to other diseases? Smallpox was a special case and probably particularly easy to eradicate, but studies are underway to find that answer. Thanks.
Hi, I think TB is in a different place than some of the other diseases, and partly the coverage rates of TB services are much lower, but also because there's a latent pool of infected people, which is going to take a long time for the epidemic to be put under control. On the other hand, the WHO and others say the end of TB, but I don't think we're at that point in many countries. In terms of your question, the point we are at is going beyond health services. So I think what we're going to see in TB, and we've already begun to see, is we've been treating people who've been coming in with symptoms, and that's been at a lower cost than actually going out and finding people. So what we're going to see in the next sort of 5-10 years is a considerable increase in cost as we spend the money to go out and find people who are symptomatic, and even perhaps those who are not symptomatic. So I suppose the TB world is anticipating this. We have very, very little data, cost data, on what those different methods of finding people will cost. So we're stepping into the unknown, and I think it's very important. We were just at a meeting last week in New York of trying to sort of understand what those different mechanisms are, and as you say, see whether they're cost effective against normal criteria. I would also say that we have even I showed you that nice graph of the treatment costs. They are estimates, they are highly uncertain. I think the only big studies in TB costs and developing these cost functions, even within treatment, as you begin to go out to more peripheral facilities, are still very scarce. And that again is something that's only going to the data's only going to be there in 2 or 3 years. So it's something in our future perhaps that will come.
Okay, I have a question from Jesse, and then Marty, did you still have a question?
Yeah, hi, Jesse Goodman, Georgetown. In sort of thinking about how you maximize the impact of this kind of really good work, and I'm thinking really scientifically rigorous economic analyses, I wanted to sort of bring attention to 2 areas and see your thoughts about them that I think are problems in all of this. One is that benefits and risks or costs change over time, and this is somewhat part of the last question that you asked. And so that when you just say something is beneficial and the cost is this and the benefit is this, that may change dramatically over a time course. And so when you're sitting down with policymakers and political systems, which do not function beyond the next election or the next headline, somehow capturing that and communicating about that is needed to overcome a critical challenge. The other one is this whole issue, which you economists will talk about as externalities, which is that the costs and benefits or risks are borne by different people, and that may also change over time. And the real importance then that there's the decision maker of day one may not own the costs and risks of day 1,000. So what's your experience in bringing these models to bear in a political or practical situation, and the need to sort of bring in all the different cost and risk and benefit holders to make this work? I mean, this is essentially, I think, the political and social problem in why societies don't behave rationally about health.
Should I go first?
Sure.
Okay, I'll go first. Great question. Great questions for the session. So first of all, I think the reality is that all of these things are dynamic. So as you noted, and we really do as analysts have to make sure we tackle the dynamics. And when I said in the polio modeling that we're doing, that we're capturing variability, uncertainty, and time, what I mean by that is that we actually have stratified the world to account for variability that exists in different countries in terms of their, current intervention use, their policies, their preferences, all kinds of things. So we don't treat all countries the same because we can't. We have to deal with uncertainty in all kinds of things, and in fact, in our model, there's a lot of, when we're talking about eradication, there are some low probability, high consequence type events that we have to treat stochastically. So we have uncertainty about what might happen and where it might happen and how that would then play out, which we also model dynamically. And obviously the transmission of the viruses within populations also happens, over time. So the answer to getting the modeling right is actually doing a lot of very deep technical work, but that's not the stuff we talk to the decision makers or policymakers about. So we talk to their staff or people that they care about, and we publish everything so that in fact people can review what's there and ask us questions, because we need to make sure everybody feels like they understand that we did in fact look at all the evidence and account for the concerns. But when it gets to the policymakers, what we generally do is try to provide specific context about the questions they're asking and help them understand why, when we look at an economic result from any point in time, the framing matters. So the estimates that we provide, I provided examples of a few analyses that looked at different questions at different times, and we are constantly trying to help people put those numbers in context and understand what does it mean. And generally what they come back to is, in the end, do the benefits exceed the costs in a way that this was a good idea? And am I doing the right thing to get that? So it depends on the level of the people we're talking with, but there are multiple audiences here. And the key thing is being able to talk to all of them. And I think that's really the answer to your first question. With respect to externalities, this is actually a real challenge for us, partly because often one of the things that we count as externalities, for example, for the polio program, are things that other people want to count as interventions that they're doing. And we can't double count at a global level, so we have to make sure that, in fact, if we count something, somebody else is not counting it, or that we're only counting our part. And I think that that's actually been a challenge in the scheme of things. So we've been pretty conservative about characterizing the externalities. But I will tell you, one of the big externalities that I see from the fact that the polio program has had this huge global activity and at least to date, probably the most significant networked surveillance laboratory and field activities, is that network has been available to support things when emerging diseases happen. So when SARS happened, even though it's a coronavirus and not a coronavirus, the people in the field who were able to go and collect samples and send stuff to labs and try to get in front of that were polio lab people. And again, with Ebola, what we saw in Africa when the Ebola stuff started to hit, there were polio teams that were dispersed to try and get in front of it, and there were polio funds that were used to support the activities to prevent Ebola establishment in Nigeria, which would have been an African catastrophe, in my opinion. So I think in terms of recognizing those system-wide benefits, we do have to figure out how to help people understand them and try to value them, but the challenge is really figuring out the boundaries and making sure we're not double counting what other people are claiming. So I'm not sure there's a good answer, but it's a great question.
Can I just ask Marty to ask his question, then you can answer both of those questions, or whichever one you choose. Marty, I think you have the last question.
Actually, given the time, Tom, nobody needs to hear my waffle. I yield to coffee break.
You yield to coffee. Okay. Would you like to comment on Jesse's question?
Will do. Not impinging on your coffee time. So I will be brief. So in the area of HIV, this questions on the costs and the changing costs and benefits, I think, is mainly relevant for drug treatments, for the cost of the ARVs. So we don't know at the moment, I think, how particularly cost of second-line drugs are going to develop, how TRIPS flexibilities will be negotiated, and what will the generic manufacturers of these drugs do as the patents run out. So there's uncertainty in our models around that. There's also uncertainty how many actually in a specific time period of patients will go from first-line to second-line treatment. So that's the first area. The second area is health system costs, particularly when we have interventions that share a similar delivery platform. How can we take account then of costs which can be sometimes quite tricky, particularly when there are economies of scope in the joint provision of interventions. And then patient costs, I think, is very relevant as well. I mean, that, of course, depends on the perspective with which cost-effectiveness analyses are conducted. We try to include the costs of to take account of informal care and the costs to children. But that's often difficult and often not warranted by policymakers who want the government perspective. I think for malaria, this question is particularly important because it's mainly the parent who takes the time costs, who has the time costs when they accompany children to the healthcare facility. But I know you are passionate about patient costs, so I will.
Well, actually, I was going to pick on that. I've got just a couple of really short answers. I mean, I completely agreed with your comment and observed that behavior many, many times. I think one of the arguments we've had in TB modeling in the last 5 years is we used to have cohort models. We didn't actually used to have these complex epidemic models that would look at cases averted. So you were saying, well, this made a strong argument. But actually in TB, we have traditionally used arguments that said, actually, we've got a cohort of people now, we will avert so many deaths, simple as, and we haven't necessarily gone into the preventative and longer term effect. And we can actually make quite a strong economic case on both grounds. When we go into the longer term effects, we bring in a lot more uncertainties, some which were mentioned about prices, but many, many other uncertainties. So I think we're getting to a point where we're presenting both results simultaneously, presenting an initial short-term result, and then saying, look, you have added uncertainty in the future, but you have these additional potential gains. Some of the things that have worked very well are the get sort of savings to the health service to say, well, at least we can show you not so much cases prevented, but we can say, for example, you can reduce your MDR treatment capacity if you do this now, and you know you're blocking your hospitals. So we've used those kind of arguments to make longer term effects resonate. But I agree it's a very difficult thing to do. And the other thing in terms of stakeholders who you're bringing into these decisions, I think one of the things that I've learned is you obviously have your sort of people who are making the top level decisions, and they will make a statement. But even at the sort of lower levels within the Treasury and within the Ministries of Health, they often can't actually spend that money. So the decision is made initially 1 year, and then you find in 2 or 3 years that money is never, ever dispersed. And I think that's been a continual sort of problem as well. So I'm more interested in not just the decision, but also the real disbursement. And I think those stakeholders and understanding how they're operating and their needs are important. Thanks.
Please join me in thanking our speakers for great presentation.